So thank you so much for the opportunity to speak today. It's been an absolutely fabulous conference so far. So, all right, we'll get into it and really switching tack from HLA to non-HLA. Let's get going. So antibody-mediated rejection, or AMR, obviously we know that antibodies to HLA are a major cause of AMR and result in poor outcome when HLA-specific antibodies are present following transplantation. However, we've also seen that donor HLA-specific antibodies aren't present in some patients with diagnosed biopsy-proven rejection and allograft dysfunction. So this indicated there was something else that was going on and potentially a role for non-HLA antibodies in transplantation. So what are the possible targets for these non-HLA antibodies? So these have very different structure and functions to HLA, with this diagram showing some of the potential targets. So many of these targets are expressed by the tissues themselves, but some are only revealed after things such as stress or graft injuries. So non-HLA antibodies can form to proteins that make up sort of the building blocks of the tissue themselves, including to myosin and actin and vimentin and collagen. And there's also a number of other targets such as MICA, which I'm sure you're all familiar with. It's very similar to HLA molecules. And this other target that I'm going to be basically talking about today is AT1R. So what is AT1R? Angiotensin II type 1 receptor, which is a bit of a mouthful, so we'll just stick to AT1R. It's a G protein-coupled receptor that mediates the action of angiotensin II, which is involved, as I'm sure you're all aware, in blood pressure control and body fluid homeostasis. So AT1R is found in multiple tissues and organs, including vascular endothelial cells, smooth muscle cells, and as well as inflammatory cells, and in tissues including the brain, lung, heart, liver, kidneys, so all of these things that we obviously transplant in solid organ transplantation. And so there are also genetic variants of AT1R that can result in altered level of expression, and also things such as environmental factors such as inflammation can also influence its expression. And unlike the regular ligand for the receptor, upon antibody binding, this results in a prolonged activation that results in the activation of multiple pathways and can potentially lead to more problems following transplantation. So the observation that AT1R antibodies cause antibody-mediated rejection was first made by Druska Dragun in 2005. And by 2012, based on her work, a diagnostic test was developed that was a quantitative antibody binding assessment in the form of a sandwich ELISA. So the assay has a lower threshold of 2.5 units per mil and an upper threshold of greater than 40 units per mil. So based on these thresholds, they designed 3 risk categories, with less than 10 units per mil of AT1R antibodies being low risk, 10 to 17 increased, and greater than 17 was classified as a higher risk category. So internationally, there's been some clinical studies that have determined their own thresholds for rejection, and the one on the left is the Cedars-Sinai study. And this was a cohort of HLA, DSA and MICA antibody negative. So in this cohort, 16 of them had acute rejection, 7 of them defined as humour or antibody-mediated rejection, and of these, 6 had AT1R antibodies greater than 17 units per mil. And in a larger study by a French group, This cohort were classified as low sensitised, so potentially some of them did have some antibodies to HLA in there. But of these patients, 37 had acute rejection, 14 antibody-mediated rejection, and of these, 10 of these 14 had antibodies to AT1R greater than 10 units per mil. So once again, providing evidence that AT1R antibodies could be not too good for transplantation. So then in Adelaide, and this study was driven by Rob, in Adelaide we had our own cohort to look retrospectively at the presence of AT1R antibodies. So there are 163 kidney transplant recipients, of which 145 were included. There were 44 rejection episodes, 30 T-cell and 14 antibody-mediated rejection episodes in this cohort. So one thing that was quite stunning in this cohort was that AT1R antibody levels were increased across all rejection types, and about a quarter of the cohort had rejection, and it was noted that AT1R levels greater than 17.5 units per mil had a rejection rate of 50%. So this is with no HLA DSA present. So furthermore, it was noted that the time to antibody-mediated rejection was related to the levels of AT1R antibodies prior to transplant, with high levels of AT1R antibodies experiencing significantly higher rejection and in a shorter time frame. So based on this, the Adelaide group implemented their own protocol. So this was similar to the protocol developed by the Dragoon group. However, the cutoffs were slightly different. So in Adelaide, all patients, all transplant waitlist renal patients are screened for AT1R antibody levels, and if they are greater than 17 units per mil, they will have a therapy of sartans and combination triple immunosuppression with tacro, mycophenolate and steroids, plus induction thymo. However, if the AT1R is greater than 25 units per mil, they also receive preemptive plasmapheresis. So after the instigation of this preemptive protocol in Adelaide, there was a significant reduction in rejection. And looking at a 2015 cohort here in this slide of 80 patients, 7 of them had AT1R antibodies between 7.5 and 25 units per mil, and they actually didn't have any rejection. And 7 patients with antibodies greater than 25 units per mil, 1 did develop a T-cell mediated rejection that did require additional intervention, and another one also did develop some T-cell mediated rejection with a vascular component. So this is the summary of the Adelaide study. So high levels to AT1R antibodies found pre-transplant were significantly associated with the development of antibody-mediated rejection in the absence of antibodies to HLA. So in 2015, the rejection rate was a fall from the long-term average, but we also have to note that this could have been associated with a change in protocol with ATG, Plex and Candesartan. So high AT1R antibodies is only present in 15% of patients. And it's also to note that some people did develop AMR with low levels of AT1R antibodies, and conversely, some people with high levels of AT1R antibodies never get antibody-mediated rejection. So there's a lot in there that we need to still unpack. But at rejection, AT1R levels are much lower than pre-transplant, so therefore rejection risk needs to be stratified on a pre-transplant sample. So since this study, there's also been a number of other studies supporting that high AT1R antibodies in kidney transplant are associated with poor outcomes. And I'm just showing you a few here. And likewise, there's also been publication showing that high AT1R antibody levels are associated with poor outcomes following liver transplantation. There's also just one paper published so far that shows that high AT1R antibodies are associated with chronic rejection in lung transplant recipients. The heart transplant literature is somewhat more patchy. Some find no difference, such as this manuscript here, and others find that they are associated with poor outcomes. However, these studies are few and far between, and a lot of them are case studies with small sample sizes, so there's a lot more work that needs to be done in thoracic transplantation. So just to take a step back, I guess, and the practicalities of it. So AT1R antibody testing is performed in my lab in Adelaide as a routine clinical test, and we are the only lab in Australia that offer this as a reportable test that we report out to clinicians. So the assay is performed once a week. We enter the results into Organ Match, and Fiona has mentioned our Organ Match system in her talk previously. We have a quick turnaround for the test, and it is reported out and the clinicians can read their results the next day, and it is a cost-recovered test in the lab. So in terms of our testing numbers, these are the numbers from 2024. We tested nearly 2,000 samples, and we've seen a huge increase over the last couple of years. The kidney transplant recipients are the most tested. However, the hearts and lungs win the most improved award. If I'd shown you this slide a couple of years ago, you would see almost 0 heart and lung patients tested. There tend to be a lot of research samples coming in for our heart lung patients rather than sort of routine clinical testing. However, the Alfred has started doing, the Alfred Hospital has started doing baseline testing for their lung transplant waitlist patients. So this slide shows the AT1R concentration across the different organ groups. So the kidney, liver and lung are somewhat similar, but the heart is way, way above. And you'll note that even though I reported that the upper limit of the assay is 400 units per mil, we now routinely dilute samples that are above that so we can get a true indication of the level of AT1R antibodies. So just exploring a bit more of the heart data, one thing that we've noticed is that patients who have a VAD inserted or had a VAD inserted have very, very high AT1R levels, so 4 times higher than patients without a VAD. How this impacts on clinical outcome following transplantation still remains to be seen, but there is a study out of St Vincent's Hospital in Australia looking at this. So I'll just share some of the data now from the Alfred Hospital, where they are now routinely looking at AT1R levels in their lung transplant cohort. So as we know, AT1R antibodies in kidneys have been associated with poor graft function, and this team decided to take a bit of a nuanced look at it. So rather than look at graft function in their lung transplant cohort, they looked at kidney function and related that back to AT1R levels. So they looked at 85 adult lung transplant patients, and the kidney function was assessed using the CKD-EPI formula from the time of transplant until the time of discharge. So this is just immediately post-transplant, with acute kidney injury, or AKI, defined as an increase in serum creatinine of greater than 26.5 millimoles per litre within the first 2 days post-transplant. So in this cohort, AKI did occur in 47% of the cohort, and it was much more prevalent in lung transplant recipients that had high levels of AT1R antibodies. So the decrease in kidney function was much more pronounced, as you can see in this slide here, indicating that positive AT1R antibodies was associated with 4-fold higher risk of acute kidney injury. So this is really a novel way of looking at the data and perhaps indicates that there are sort of multiple pathways that are associated with AT1R antibodies in transplantation. It doesn't necessarily just act on the allograft itself. So in summary of this part, the presence of pre-transplant AT1R antibodies has been shown as an independent risk factor for long-term graft survival and acute rejection in kidney transplant recipients. There's more work to be done when it comes to liver and heart-lung transplant patients. So we've noted that there are much higher AT1R antibody levels in heart transplant recipients, and haven't shown the data here, but also there's much higher AT1R antibodies in paediatric kidney transplant recipients. And pre-transplant AT1R antibodies were associated with acute kidney injury following lung transplantation. And we think that testing AT1R antibodies prior to transplant could be helped to stratify the immunological risk of antibody-mediated rejection following transplantation. But however, the mechanism of action behind this does require future research. So I've talked to you about AT1R, but AT1R is really the tip of the iceberg when it comes to non-HLA targets. So there are a number of other targets, and some of them listed here, that can develop antibodies following transplantation. So these are specific autoantigens. As I mentioned before, they are primarily expressed on endothelial and epithelial cells, and there's emerging evidence that a number of antibodies to a number of these targets can be associated with poor graft function following transplantation. So just going back to our lung studies, we have expanded beyond AT1R to look in this cohort, and the Alfred team are really active in pursuing mechanisms behind chronic lung allograft dysfunction, or CLAD, because it's the leading cause of mortality following lung transplantation. And as you can see here from this slide, whilst the 1-year survival rate following lung transplantation is similar to the other organs, the 5-year survival rate is far inferior, and this is largely due to CLAD. And so the group are actively looking at ways to predict CLAD and also to look at different forms of treatment once CLAD occurs. So the lung transplant cohort are very different to the kidney transplant cohort. So often the underlying disease can also lead to the development of autoantibodies prior to transplant. So this prompted us to ask the question is there, beyond AT1R antibodies, is there some patterns of antibodies to different targets that are associated with the development of rejection following lung transplantation? So we looked at a cohort of 68 adult lung transplant recipients in a retrospective study where we had stored sera from these patients, and we had all the matching clinical information with a median of follow-up of 5.5 years. And we used the 1 lambda autoantibody assay that has 39 targets. And we looked at sera both pre-transplant and at 12 months post-transplant, and looked at the correlation with clinical outcomes, and particularly with CLAD. So this is the 1 lambda Luminex panel that we used. So it's a bead-based assay, much like Rhonda and Fiona have introduced in identifying HLA antibodies. So I'll really just cut to the chase here in terms of time, but the take-home message was that there was a lot of data that you get off of this panel, but there is almost a unique pattern of reactivity to individualised patients that makes it quite difficult to interpret. But really the take-home message is that the number of positive targets was important. So in this figure, we show the recipients free of CLAD on the y-axis and time post-transplant on the x-axis. So we showed that when the cohort was separated into two groups, that for patients that had 8 or more positive antibodies, they had increased incidence of CLAD and a shorter time to CLAD. So this is completely irrespective of what the target actually was. And so now just looking at some of the individual targets that came up. So this is the impact of having antibodies to these particular targets when the antibody was present prior to transplant. And these targets listed here had independent association with CLAD post-transplant. And it's also important to note that a couple of these targets had also been implicated in rejection following heart and kidney transplantation. So likewise, developing antibodies to several targets after transplant was also associated with rejection, with positivity of these targets at 12 months being independently associated with CLAD. And once again, there's a few of these targets that have been shown up in previous studies. So non-HLA antibodies, some take-home messages. So a role for these antibodies in transplant outcome has really only emerged pretty recently, and the literature is fairly sparse and somewhat patchy. So we found an increased number of non-HLA antibodies was associated with rejection following lung transplantation, but we really need probably very, very large cohorts to work out specific targets of interest. So I guess the sort of more bigger questions that we need to answer are these antibodies actually causing the rejection, or are they just a marker that something bad is happening in the post-transplant course? So there's a lot more studies that need to be done to determine the mechanism of injury. However, that aside, we do believe that testing for non-HLA antibodies prior to transplant can be helpful to guide both in terms of immunological risk and to potentially guide immunosuppression to avoid antibody-mediated rejection. So thank you to everybody who's involved in this study, most notably this fella here who's here and gave a talk yesterday, and his poster includes a lot of the data that I showed on the extended non-HLA panel. So Steve Hyho, thank you for that, and your statistics wizardry is second to none. And also to my own lab that do all of the testing, analysis and reporting on the AT1R results, and particularly to Sue and Tim and Rob, who without their help this presentation wouldn't have been possible. And thank you to Mary for letting me have Steve to support a lot of these studies. So we have a really excellent working relationship with the Alfred Hospital. They're so supportive of our studies and sharing their data, and particularly Greg Snell and Glenn and Bronwyn, the clinical team, and Andre Darry is a visiting physician from Switzerland who's been working almost entirely on AT1R and non-HLA since he's been in the lab, in the hospital. And also thank you to the funders, and particularly last and definitely not least, thank you to the lung transplant patients at the Alfred who sign up to all of these studies, and without them, this absolutely wouldn't be possible. So, thanks for your attention.
And now it's time for the question. Yes, please.
Happy that I got my voice back. So so in your slide where you showed that there was a lot of patients who had high levels of AT1R that did not have rejection. So was there anything in the group that had rejection, any kind of different signature that we might be able to make a risk assessment versus those group? Because you don't want to treat patients if you don't have to, because that's not without risk.
Question that Rob can answer. However, when we're looking at the kidney patients and the non-HLA panel, that's what we were trying to tease out, and we had like a pristine group, and a group that had high A2NR, and we thought maybe some of the other markers would come up, and that would be a good way of sort of, you know, working out who was actually more at risk. And it just didn't turn out that way. Like, it was quite diverse in terms of the other markers that came up. However, I think often, it's probably more of a question for Rob, but there might need to be some other event that kicks off. So the A2NR antibodies can be there, and we do know from our own studies that if they are high prior to transplant and they stay high, those patients are okay. If they are high and they go low, that's bad. And if they're low and they go high, that's also bad. So you're absolutely right. There's something that we are still missing, and maybe there's some injury that happens to the kidney, and then the A2NR antibodies are, there's more antigens, and it kicks off.
HLA sensitization, I mean, not that they had DSA necessarily, but if they were more highly sensitized, were they more likely to have a rejection episode, or even ABOs? I mean, something that might not be in the realm of an autoantibody, but some other factor.
So I don't believe we show that in that study, because the people with HLA antibodies weren't included, but there have been other studies that do show if you have antibodies to HLA plus antibodies to A2NR, it's not a 1 + 1 = 2, it's a 1 + 1 = 4. So yes.
So those, I mean, that might be a group that you would target intentionally versus somebody who had no DSA and a lower risk.
That didn't really come out though in our lung cohort, so.
Well, like you said, that's a whole different
It's
organ.
a whole different, yeah, exactly.
Thank you.
Thanks.
Any other questions?
Good morning. I am a resident from the Antibody Hospital. Thank you for your wonderful presentation, and I would like to ask why the patient with the kidney graft rejection that has the high level of pre-transplant AT1R, but not at the time of rejection. Could you explain why the level is high in the pre-transplant, but not at the time of rejection?
I don't understand the question, sorry. Oh, you mean what I just said to Kathy? So, sorry, that wasn't at the time of rejection. So in patients that are doing well, they can have high AT1R levels pre and post, and with no rejection. But in patients that have high AT1R prior to transplant and then low at rejection, it could be that the AT1R antibodies are binding onto the graft itself. And that's why they're not in the circulation anymore. Does that answer the question?
Yes.
Yes?
Yes, thank you so much.
Thank you.
Is there any question from the floor? Okay, so it's time for the meeting, for the break. So thank you.